Hello, everyone. Welcome to today's webinar entitled Revolutionizing Wet Age-Related Macular Degeneration Care, Explore Emerging Therapies and Game-Changing Clinical Insights. Here's today's agenda. We'll start with challenges of current treatments, and we'll go over some aspects of tyrosine kinase inhibitors, and we'll end with a panel discussion and question and answer. My name is Judy Kim. I have the pleasure of moderating this webinar. I'm professor of ophthalmology and vice chair of education and medical director of clinical research at UT Southwestern Medical Center at Dallas, Texas. And I am so happy that Dr. Catherine Talcott, good friend of mine, an amazing vitreoretinal surgeon, has joined today's webinar. She's an associate professor of ophthalmology at world famous Cleveland Clinic.
I'm so happy to be here with you, Judy.
Wonderful. And here are our disclosures. And here are three learning objectives. After today's webinar, we hope that you can discuss the current unmet needs of patients with neovascular AMD. Secondly, you can describe newer therapies in the market. And finally, we hope you can appreciate the newer clinical trials demonstrating durability. This activity is jointly provided by Clinical and Patient Educators Association, as well as iVista Medical Education, and is supported by an independent medical education grant from EyePoint Pharmaceuticals. And you can get CME credit for joining us at the end of the program. An email will be sent with the instructions how to claim, and you can print your certificate afterwards. And we really want you to be engaged with us, ask us questions. We'll try to answer as best as we can. You can put your questions in the box below, and we'll get there. So without further ado, I will kick off this webinar by discussing the challenges of current treatment. First of all, the last 2 decades have been revolutionary in terms of how we treat patients with neovascular AMD because of the advent of anti-VEGF agents. The first anti-VEGF medication was approved by FDA for ophthalmic use for neovascular AMD in December of 2004. And do you remember what that was? It was pegaptinib. Right?
Yes.
So pegaptinib kicked us off, but then since then we've had a number of other agents, both what we call first generation and second generation anti-VEGF. But these anti-VEGF agents do require frequent injections, and it can range anywhere between every 4 weeks to every 16 weeks with the newer agents. But what we have found over and over again over the last 2 decades is that unlike clinical trials, in the real world, there is under-treatment. In the clinical trial, for instance, with the first generation ranibizumab and aflibercept 2 milligram, the injection frequency was anywhere between 7 to 12. That resulted in anywhere between 7 to 11 letters of vision gain. However, in the real world, we only used anywhere between 4 to 8 injections in the first year. As a result, the visual acuity gain was dismal, between 2 to 5 letters approximately. And this was seen over and over again with many other studies. This table pretty much summarizes what was said before, that both in neovascular AMD trials as well as in diabetic macular edema trials, there were many more injections given, and there was a very robust visual acuity improvement. However, in the real world, the number of injections were far below what were used in the clinical trials. As a result, visual acuity gain very minimal. In the real world of neovascular AMD, in this compilation of studies, 0.4 to 1.1 letter gain, which doesn't come anywhere close to the clinical trials. Luminous was another study that looked at the number of ranibizumab injections throughout the year. And the study found that during the first year, about 3/4 of patients got less than 6 injections. So 5 or less injections were given. And that has consequences, meaning visual acuity gain. Why? Because look at this. This is another study that looked at the electronic medical records between 2012 to 2016 in a retrospective fashion. And the bar graph shows the number of injections throughout the year, 1 through 13. Most were between 7 and 8. The highest number was between 7 and 8 injections per year. But what we see with the orange dots is that until you get to at least 7 injections per year, there was no improvement in visual acuity. In fact, if it were less than that, many lost vision. But once you get to 7, 8, 9, visual acuity starts to improve, and around 10, 11, 12, that's when you get the maximal improvement of visual acuity on average. So again, number of injections directly correlate with the number of letter gains. And this is another study by Kin et al. Looked at 5-year visual acuity outcomes. And again, various studies showed that the more injections the patients got throughout that 5 years, more visual acuity gains were seen. So if more injections, better visual outcome, why can't we do that? Why are we ending up with undertreatment in the real world? Where there are a number of barriers, and some are listed here. Caregiver burden. Many patients with neovascular AMD are elderly, and they rely on their family members to bring them to doctor's office. That means their younger family members or neighbors or whatnot, they have to take time off from whatever they're doing. Could be time off from work, and they may not be able to get all that time off. Our patients have other comorbidities. They're elderly and they may have hypertension, diabetes, other things that are going on, and financial burden. We cannot ignore the money aspect of this. Every time the patients come to our office, they may have to pay copay. Some patients have lots of deductible. All these do put undue stress on our patients. And in some patients, vision does not improve and they become disenchanted and they may not want to continue the treatment. So they may end up discontinuing the therapy despite the fact that we recommend them to have more injections. So let's talk a little bit about the discontinuation of treatment then. In this study by Ladd and colleagues, they studied over 459,000 Medicare recipients with 621,000 eyes that received anti-VEGF treatment for neovascular AMD. Demographics show that most are Caucasian, as we would expect for neovascular AMD. Twice as many females than males, mean age of 81. What the graph on the right shows is that when they defined discontinuation as 12 or more months without anti-VEGF treatment, they found that 17% of patients with neovascular AMD stopped treatment after just 1 injection. And a little more than half, 57%, discontinued within 12 months. And 3/4-ish, 71%, discontinued within 2 years. So this aspect of treatment discontinuation is not something that we can ignore. So let's look at another study. This was a large study looking at American Academy of Ophthalmology's IRIS registry by Wyckoff and colleagues. looking at the impact of anti-VEGF treatment and patient characteristics on vision outcomes in neovascular AMD over 6 years of analysis. What we see on the left graph is that patients with better visual acuity at baseline and better follow-up visual acuity were more likely to have longer follow-ups. So remember I mentioned that some people may discontinue because they're not improving as much, but people who do improve or who continue to have good vision may be more likely to stay with the treatment. On the right-hand side, we see a graph that shows that after a mean visual acuity increase of 3 letters at year 1, it followed with loss of vision, net loss of vision from baseline. And at year 6, there was about 4.6 letter vision loss. So they may improve initially, but they lost vision overall when we looked at 6 years. What were some of the factors that related to vision loss at year 1? Well, older age, maybe because they're harder to come in, men, Medicaid insurance, and not being treated by a retina specialist and by a general ophthalmologist instead. So those are interesting factors, I thought, from this study. Again, in this study with AO IRIS Registry, they showed a decline in number of injections. First year, 7.2, but by year 3, it plateaued out at about 4.6 injections per year. And the interval between injections ranged between 7 weeks to by year 5, it was about 15 weeks. So it did get increased quite a bit as the treatment went on. Also, they found that nearly 40% of patients discontinued treatment in less than 2 years. And the duration of discontinuation was about 89 weeks on average. Many patients also switched therapy. About 32% switched between anti-VEGF agents, and most got switched from bevacizumab to on-label, and the switch happened about 81 weeks after the initial treatment. So they concluded that when they modeled this frequency of injection and visual acuity, et cetera, again, they concluded that more injections, a better visual acuity outcome. And difficulty with continuous adherence to frequent intravitreal injections may have contributed to under-treatment, resulting in less than optimal vision outcomes. So if there are any ways we can come up with to reduce the treatment burden, reduce the frequency of intravitreal injections, but end up with visual acuity gain, that would be the holy grail, right? That's what we would want going forward. And finally, this last study that I would like to summarize is Singh et al., looking at sufficiency of treatment based on IRIS Registry, which has over 2 million eyes in the data set. They looked at treatment-naive eyes with neovascular AMD with visual acuity 2400 or better. And they divided into eyes that were actively treated, defined as receiving at least 3 months, receiving anti-VEGF within 3 months of diagnosis, and then eyes not actively treated, that the eyes that did not receive anti-VEGF within 3 months of diagnosis. And among the eyes that did receive within 3 months of diagnosis, they divided that into sufficient treatment, defined as 7 or more injections during the first year, which resulted in 109,000 eyes, versus insufficient treatment, less than 7 injections during the year 1, that resulted in about 74,000 eyes. So this was their study design. What did they find? They found that, again, number of injections and duration between injections varied quite a bit, statistically significant difference between sufficient treatment group versus insufficient treatment group. In the sufficient treatment group, about 9 injections given insufficient treatment, 4 injections, and duration between injections were 44 in the 44 days in the sufficient treatment group and 78 days in the insufficient treatment group. And that translated to difference in visual acuity outcome, 3.4 letter improvement in the sufficient treatment group, and possibly a little bit of a vision loss in the insufficient treatment group. So if we can do anything to keep our patients to adhere to therapy and prevent discontinuation, it'll be great. What are some methods? Perhaps our discussion with our patients before we even start the treatment, letting them know that anti-VEGF therapy is a long-term treatment. Sometimes I tell my patients, they ask me, how long is it going to go on? I say, it's either you die or me die. It's going to go on for a long, long time. And let them know that interruptions in treatment can result in irreversible vision loss. And we may want to follow up with patients who miss appointments. Right now, it might be difficult to do, but with AI, it might light up all the patients who didn't show up. So we might be able to capture them a little better and contact them. We may want to make our visits more desirable, less onerous with long waits for our patients so that they might be more likely to come in. And we need to thoroughly educate our patients and make them partner in our efforts to treat and get best visual outcome. But there may be other ways that we can improve our patients' vision without as frequent injections that we have been using. And that might be a tyrosine kinase inhibitor or other mode of action. So at this point, I would like to pass the baton over to Kat.
Thanks so much, Judy. That was such an excellent summary. I think we're so fortunate to have so many different tools in our toolbox in the anti-VEGF space, but, we're still not able to sort of be able to make sure the patients that we're treating with neovascular AMD are getting visual acuity gains that we know are possible and in a way that fits into their life. So I think one thing that might potentially help to change the way we treat these patients is by tyrosine kinase inhibitors. So I'm going to just provide a summary of this sort of emerging class of medications. So our current anti-VEGF therapies that are really sort of the mainstay of our treatment for neovascular AMD selectively target actually only extracellular VEGF-like receptors. So these bind selective ligands, including VEGF-A, to really help prevent receptor binding. And they prevent like pro-angiogenic activities. And these are the things that we sort of do day in and day out by injecting into patients. However, there's a class of medications called tyrosine kinase inhibitors that, rather than working extracellularly, actually work intracellularly to be able to inhibit the receptors. And this allows for the inhibition of ATP binding. It also prevents activation of pro-angiogenic signaling. And some of our colleagues, including Dr. Singh, who you had mentioned before, has actually sort of written a nice review article on sort of this emerging class of medications that these might potentially be a durable treatment option for neovascular AMD. So over the course of sort of the next few minutes, I'm going to go over some of those medications and why they might help. So there's different medications that are being delivered in the space, and there are differences in their platforms and how they're delivered, which is sort of given here. There's axitinib, which is OTX-TKI from Ocular Therapeutics. This is redosed every 6 to 12 months and is given as an injection. The same investigational medicine is also being developed by another company, Clearside, as a suprachoroidal injection, which would be redosed every 6 to 12 months as well. So those are sort of similar medications, but just given in different mechanisms. Vorolanib, or EYP-1901, is made by EyePoint Pharmaceuticals and is also given as an injection as well, and it would be redosed every 6 to 12 months. This slide definitely takes me back to medical school, primarily preclinical years, where we learned about pharmacokinetics. And so if you don't remember, IC50 is really the measure of a drug's ability to inhibit a receptor activity by half. So you basically want to make sure that if a drug is working, that it doesn't drop the dose below the IC50. If you get above that, there's really little to no additional therapeutic benefits. This graph here is a little busy, but is sort of preclinical studies looking at different tyrosine kinase inhibitors and their activity on different receptors, including VEGF-R1, R2, and R3 in those top 3 graphs. And a number of the TKIs sort of shown here, while they do have different IC50s, all of these medications are able to have potency where they're above the IC50 for these receptors, showing that they have activities at these receptors. So I'm going to, now that we spent some time talking about sort of the preclinical and mechanism of these medications, let's dive into some of the sort of more clinical information that we have about this. So tyrosine kinase inhibitors, there's multiple of them, and phase 2 and 3 studies are underway. So I'm going to sort of break them down by different agents. Exitinib, which is OTX, is given as an intravitreal implant. It's polyethylene glycol-based hydrogel fiber containing a TKI that's injected into the vitreous. It was studied in a phase 1 study. You can see the design here. It was compared to aflibercept, standard of care, where the aflibercept was given every other month. But in the phase 1 study, this was given in addition to an aflibercept, and then patients were watched and monitored to see if fluid came back, if patients lost vision, or if there was any hemorrhage. Here are some of the main results from that phase 1 study, looking at sort of vision and CST. These graphs may look a little different than we're sort of used to seeing for sort of neovascular AMD studies, because we're really making sure that these patients just have stable vision and have stable CST. And you can see in the top graph that there's no significant difference in between the mean change in vision between the OTX TKI arm and the aflibercept arm. And similarly, both fluid was controlled in terms of mean change in CST, well in between the 2 different arms. You may note, though, that the aflibercept arm in the yellow has a little bit more sawtoothing, which means that there's probably more fluid fluctuations in those patients than in the TKI arms. One of the things that I think these medicines can be really helpful for is reducing burden. So this is sort of looking at how many patients were able to go without getting rescue injections with something like aflibercept at each visit. And we know that the implant here resorbs at about 8 to 9 months. And you can see sort of up until that point, patients were really doing pretty well. Only 73% or 73% of them were able to go without getting rescue. You can see as time goes on that more patients need to be rescued, but a lot of these patients didn't need to be rescued when they had the TKI. This is the graph that kind of really highlights the potential benefit of these medicines to me. These patients who were enrolled in the study, you can see by the amount of yellow, orange, and gray dots on the left before getting sort of treatment, really needed a lot of injections. And then you can see after treatment that there's much less of those dots, indicating that there were less supplemental injections. So these patients actually had an 89% reduction in treatment burden. This was found to be very safe in the phase 1 study. There were no reports of ocular or systemic serious adverse events. There was 1 episode of endophthalmitis after a mandated aflibercept injection. So based on these results, the company is pursuing 2 different studies that are very different, the SOL-1 and the SOL-R study. The first is a superiority study comparing OTX TKI to aflibercept, Both of those are just given once, and patients are followed and treated if they meet supplemental criteria. But the primary endpoint for this study, which is different than we see in a lot of neovascular AMD studies, is actually the proportion of patients who are able to maintain vision, which is defined as less than a 15-letter loss at week 36. There's also a non-inferiority study that is one of the two phase 3 studies. That's a more like traditional design that we're used to seeing, compared to aflibercept 2 milligrams every 8 weeks, as well as aflibercept 8 milligrams every 24 weeks. All right, so let's change gears. So let's talk about EYP-1901. This is a pan-VEGF inhibitor. It's a biodegradable intravitreal implant. And it was actually initially tested as an oral agent for neovascular AMD in phase 1 and 2 studies. Because of some liver toxicity issues, the phase 2 was halted. So now it's being developed as an intravitreal injection. Here is some data from a presentation given at ASRS last year, which looked at the pharmacokinetics of this agent, which really showed that there was an initial burst of the drug being released, really followed by an extended steady state above that key IC50 and sort of the targeted retinal tissues. There are a fair amount of studies looking at this agent in neovascular AMD, starting with the DAVIO study, which is a phase 1 study. They had 4 different doses: low dose, mid dose, and high dose. And while the primary endpoint was safety, the company was able to look at efficacy as well. The most important thing that's sort of striking about the baseline characteristics for these patients is these are really patients who needed a lot of injections. They needed somewhere between 8 and 9 injections in the year prior to being enrolled in the study. And then here are some of the results looking at sort of the mean change in vision from the screening visit. You can see it's pretty stable, as well as the mean change in CST from the screening visit, which overall at the end of month 12 was very stable. But when we look at sort of the treatment burden, you can see that there was a significant decrease. As mentioned before, these patients were really ones who got a lot of treatment, averaging between 8 and 9 injections beforehand. And you can see by the amount of sort of black dots on the right, which indicates when they got supplemented. Some patients needed to be supplemented, but overall there was a reduction in treatment burden in 73% at 12 months. Based on the results of this, the phase 2 DAVIO 2 study was performed, looking at a 2 milligram low dose and a 3 milligram high dose of EYP-1901 compared to aflibercept. The patients in the experimental arms were loaded with 3 doses of aflibercept and then received EYP-1901. And the primary endpoint was looking at that blend of week 28 and 32 to be able to see vision. Patients were able to get supplemented with aflibercept if they met certain criteria. And you can see here that the primary endpoint was met in terms of vision. There was no significant difference between the gains, as well as CST stayed very stable overall. Though you can note again that in the aflibercept arm, there was a lot of sawtoothing in that curve, indicating that these patients had a lot of fluid fluctuations, whereas patients in the EYP-1901 arm did not, maybe suggesting that their fluid was better controlled. And then looking at sort of treatment burden, a lot of patients were able to go without supplemental injections. At month 8, 63% of patients in the EYP-1901 arms were actually able to go without getting any supplemental injections. And then perhaps most impressively is looking at sort of injection burden. These were patients in the DAVIO 2 study who really got a lot of injections before being enrolled in the study. And then afterwards, patients were able to get a 81% reduction in injections in the 2 milligram arm and an 80% reduction in the 3 milligram arm. This agent was very safe overall. There were no episodes of the insert migrating to the front part of the eye and no cases of retinal vasculitis as well. And so based on the results of this, there's going to be 2 phase 3 studies that are actively enrolling patients, looking to see if vision can be maintained and what the difference in treatment burden will be for these patients. All right, so finally, we're going to change gears a little bit and talk about one of these tyrosine kinase inhibitors that's not given as an intravitreal injection, but is actually given as a suprachoroidal injection. And the benefit of that is potentially sort of staying out of the eye. So this is the Clearside axitinib, which was studied in the OASIS phase 1/2 study. It was an open label study. Here are some of the 6-month results from that study showing that patients, when they were switched over to this and they were previously treated neovascular AMD patients, were able to maintain a stable vision, but also their central subfield thickness remained stable as well. These patients similarly had a lot of treatment beforehand, and you can see if they were supplemented after the green dot when they received one of the suprachoroidal injections. These patients afterwards, especially in cohorts 3 and 4, at that certain dose level, really did not need a lot of supplementing. Based on this, the phase 2b Odyssey study was performed, which compared the suprachoroidal injection to aflibercept. Interestingly, compared to some of the other studies that we talked about, patients in the Clearside axitinib group were actually able to receive more supplemental suprachoroidal injections if they met certain criteria at weeks 12, 16, and 20. So that's a little different than the other trials that we talked about. And sort of based on the results found in this study, vision was really shown to be sort of stable in the phase 2b Odyssey study, as well as patients were able to maintain stable anatomic control and reduce the fluctuations, especially when patients were looked at week 36 after enrollment in the study. So overall, the study found that they were able to have stable vision up to week 36, and patients who were really difficult to treat needed a lot of injections, and that the injection frequency was actually able to be reduced by nearly 84%. Similarly, the treatment was well tolerated and this is actually the only phase 2 study that allowed for repeat TKI dosing data, which is a different. One of the things that's interesting about these studies, and is really important, is what are the criteria for patients being able to be supplemented. You can see the difference here for the suprachoroidal injection. They could receive supplementation if there was an increase of CST greater than 100 microns. In the EYP-1901 arm, it's actually more than 100 micron increase from the lowest CST for 2 consecutive measurements. In OTX TKI, there's actually no separate CST change. So some differences to note sort of between these studies. So overall, I think TKIs are sort of an exciting advancement that we need to watch and see how they do in clinical trials. They really beneficial in that they allow for this pan-VEGF intracellular mechanism of action. There's different ways that they're being investigated in terms of how they're delivered into the eye. And so far, there doesn't seem to be any evidence of a significant dose-related toxicity. Dr. Kim, I think you're just muted. Sorry.
Thank you. Well, Dr. Talcott, that was wonderful. You just put all the exciting stuff that's going on in the TKI world into a very succinct manner and presentation here. But let's go down a little bit deeper and see, how TKIs might fit into our everyday management of our patients with neovascular AMD with cases as an example. So why don't you start off, Kat, with your first case?
Yeah, I would love to. Yeah, that was a lot of data we all gave in quite a short amount of time. So I think it'll be interesting to sort of see how we think about this might affect the patients we take care of. So this is a 78-year-old patient of mine. She was previously followed for intermediate AMD, and now she's having vision changes in her left eye. She's a strong family history of AMD. She's a mom and 3 sisters who have it, and she started noticing some vision changes on her Amsler grid a few days ago. So this is her right eye. Vision's excellent 20/20. You can see that there's some drusen that are there, but no subretinal fluid or intraretinal fluid seen on the OCT. But in the left eye, she really has this large PED. She doesn't have too much subretinal fluid seen, at least on this B scan. But this is actually what she looked like 4 weeks prior to presentation when her vision was 20/20. So a huge change in sort of her PED. This is actually before I started inheriting her, but my colleague at Cleveland Clinic started her on anti-VEGF injections and then switched her over to aflibercept after one injection. So 4 years later, she has now received 34 injections in her left eye. And unfortunately, she's really not able to be extended on aflibercept past 6 weeks. She then presents to me when she's had a change in vision in the right eye for the past few days. Here are some photos we got from that first visit. Although she's 20/20 in the right eye, you can see that she does have a hemorrhage that's there. And in the left eye, for which she's been getting a lot of treatment for a while, she's 20/20 without hemorrhage. On the right eye, you can see that she's got hemorrhage on the infrared photo over on the left, and on the OCTB scan, she's got PEDs and subretinal fluid as well, suggesting conversion to exudative AMD. And on the left eye, although her vision is 20/20, she's 6 weeks out from aflibercept, and you can see that she still has significant subretinal fluid, even in just this 1B scan. Although in the fovea, she doesn't have subretinal fluid. So I initiated treatment on aflibercept for this patient in both of their eyes, and she subjectively improved on aflibercept at 5 weeks after multiple injections, and the hemorrhage was actually able to go away. So this is kind of what she looked like after we got through that initial treatment. The right eye vision is 20/20. There's no fluid that's there. And then this is the left eye. There's no fluid that's present on her OCT as well. But, 5 weeks, doing injections every 5 weeks is really difficult. So I've tried to extend her before. And when I do that, she really notes that she has more difficulty reading. This is her right eye. 6 weeks after aflibercept, she has fluid where she didn't at 5 weeks. And on the left eye, she has sort of fluid as well. Judy, the thing that I was kind of struck by with this patient is although her vision is so good, there is fluid there and she is noticing it. Is that something you've noticed in your patients too? That sometimes patients will subjectively notice things even though their vision measures quite good?
Yeah, definitely. And I think we really have to listen to our patients. Sometimes the visual acuity is good, but then they complain about dim light, not being able to see well in certain lighting conditions as well. Or when they first wake up in the morning, they have these, dark areas and so forth. And then it takes time for them to adjust. So yes, Snellen visual acuity is one thing, but it does not translate, completely to what the patients are functioning at. I was curious, are you injecting bilaterally with this patient with each visit? Because, obviously she's already a frequent needing anti-VEGF, frequently needing anti-VEGF in both eyes. And, doing one eye at a time would mean even more visits. So what are you doing?
Totally. Yeah, I'm a big fan of doing both eyes at the same time. It can be a little bit much for some of our patients to go through with having the irritation after getting an injection with both eyes. But, safety studies have found that there's no increased risk of endophthalmitis if you do them both on the same day. And I have found I have one or two patients who get injections at a frequent interval in both eyes and refuse to get them done on the same day. And I just find that they inevitably have delays in care between the eyes. Like maybe they're away for a week, you're away for a week. And although you intend to sort of see them back every 2 to 3 weeks, there just ends up being delays that you don't intend. And I think it's just much better just to do them at the same time. I was
And
curious.
I think when we were using a compounded bevacizumab, we sort of stressed the using different lots.
Yes.
But are we not as worried about endophthalmitis when we use same lots? Because we don't always have same, different lots for aflibercept or even bevacizumab or other things.
Yeah, I think that's hard to sort of control, depending on where you're at. And to be honest, I don't look at that as much. I was curious at this point, although I'm able to control this patient's fluid pretty well and keep her seeing well. Would you consider sort of switching agents at this point? Would you just keep her bring her back at 5 weeks and just keep her at 4 to 5 weeks? How would you sort of approach that in this patient?
Yeah, so this all depends on where in that continuum graph that I showed in the beginning, are we still in the first generation anti-VEGF era? Then, there's nothing besides aflibercept 2 milligrams. But if we were a little bit later, where we have aflibercept 8 milligrams even, or faricimab even, one option is try to look at one of these two agents, the second generation, as we call it.
Mhm.
Um, one option is try aflibercept 8 milligrams, since she does respond to aflibercept 2 milligrams, and see whether you can get extra couple of weeks by
Mhm.
switching. Or faricimab is interesting in that it's got additional a mode of action besides anti-VEGF. It's got anti-angiopoietin 2 inhibition effect. So, I think maybe switching to faricimab might be another possibility.
Yeah, I think that's a great idea. Um, Great minds think alike.
All right.
I was a little bit hesitant, although she responded really nicely to aflibercept, to switching to aflibercept 8 milligrams, just because if I wasn't able to get to 8 weeks, just with the way that the label is, I was afraid I was going to have to switch back. So I tried faricimab first for this patient, and she does better. This is her 5 weeks after faricimab. She doesn't really have sort of any fluid that's present there. Unfortunately, though, I've like slowly tried to extend her on faricimab, and her vision again just gets subjectively worse if I go longer. This is her at 8 weeks. You can see she's got more fluid, although she's 20/20. She definitely notices it more, is having trouble, more trouble reading. And then this is the left eye, which again shows more fluid sort of at 8 weeks. So, I've now gotten her stable on faricimab sort of every 6 to 7 weeks. You can see that she doesn't really have that much fluid there, but this is a patient who, I'm curious to hear if you have patients like this too. And I know you've put a case together, so I'm looking forward to seeing that. But now she's had 32 injections in the right eye, 76 in the left eye. She's gotten 9 injections in the past 12 months. And, although her vision measures, which she qualifies as good when she extends, or measures good when she extends, she doesn't feel that way. She's okay coming in pretty frequently. She's worried that if we extend her, her vision's going to get worse. And I've actually tried to see if she's a candidate for sort of other studies in the past that are given via different like mechanisms and modes of delivery. But as you can imagine, when she's properly refracted at a clinical trial screening visit, her vision's actually 2015. So based on her vision, she actually has not been able to qualify for studies I've screened her for before. So I'm sort of curious, I know we spent a lot of time talking about tyrosine kinase inhibitors. Is this someone you would consider, if tyrosine kinase inhibitors were sort of approved and available, would you consider someone like this switching to that?
Yeah, I mean, well, first of all, kudos to both the patient and you and the previous physician for, continuing the treatment and staying with the therapy. And yes, there's fluid, but her vision is 20/20 on Snellen visual acuity chart. And that is the beauty of anti-VEGF therapy, right? But
Mhm.
can we do better? Can we reduce the treatment burden on this patient? And I think, different drugs with different mode of action, such as tyrosine kinase inhibitor, may be definitely an option where, this is where new drugs with new mode of actions may come in and help our patients. So it is definitely an exciting time. And
Yeah,
yeah,
I
the
think
2015, yeah, ETDRS visual acuity, it's always better.
I know it's funny when you're looking for patients and thinking if they're candidates for trials. I always mentally expect that they're going to measure at least 2 lines better when they when they get screened on the
Yes,
TDRS,
I
which
think
is
that's
funny.
correct. Well, let me go on to my case, which is another case of refractory neovascular AMD. This patient, left eye is totally fine, but the right eye, 2200 vision with, again, large pigment epithelial detachment. This patient, we started right away with aflibercept 2 milligrams. And after 9 injections with aflibercept with 4-week dosing, vision did improve, and you can see the PED has improved as well. And after 15 injections, she still chugs along at 20/70 visual acuity. But we try to extend out 6 weeks. She recurs with fluid. Then we go back to 4 weeks, and then we try again 6 weeks, and then we just can't go beyond 6 weeks for this patient. What do you do?
Yeah, these patients are really tricky with the large PEDs. I was actually one of the things that I get afraid about, when I start seeing these patients who have PEDs, especially when I start treatment, is what happens if the PED collapses or if there's a rip. I was really happy to see that that didn't happen for your patient. And it looks like actually over time the PED did decrease a little bit. But these patients just tend to be really recalcitrant and I think difficult to treat sort of no matter what we do. I mean, I think that your patient has responded sort of nicely and you're able to control some of that fluid, but with the 20/60 vision and the way that looks, you just wonder if you're able to get them drier, if they would be able to sort of see a little bit better. You could say to the patient, like, I'm only going to see you every 4 weeks, but it's not practical and really hard for patients and their caregivers for the things that you sort of mentioned. It depends again on when you're seeing this patient, but this might be someone who I might switch over to one of the second generation agents. You could consider faricimab sometimes, as you did there, because sometimes with the Ang2 effect, I think that might have a nice impact on PEDs, but it looks a little bit better, but not dramatically better. You could consider, aflibercept, 8 milligrams as well, but I'd be afraid that you wouldn't be able to get out to 8 weeks on this patient with recalcitrant fluid.
Yeah, some of the sub-analyses are showing that faricimab may have a good response for eyes with PED, so that's why I switched over to faricimab. But after one injection, the fluid did get better, but PED really didn't change. But after number of injections, so at the bottom you see after 12 injections, it seems to collapse. But there's still some residual fluid. It didn't totally dry out, and so we're continuing on every 6 to 8 week faricimab. So, is this a patient that you might consider TKI?
Yeah, I think it's something to for sure consider. I think the nice thing about the way our toolbox now is as retina specialists is we have lots of different things we can try, right? We can try sort of off-label, and then we can try sort of on-label and second generation agents. Some of that, and a lot of that is just dictated by insurance now. But, when you're in the situation like you have, where you've really exhausted sort of all your options, you're also fortunate that this patient and you have stuck with the frequent treatment. I think a lot of our patients, it just feels like that sort of burden is too much, or there's a gap, they get hospitalized and then they can have like a big bleed or something like that. But I think that this is a patient where I'm definitely paying attention to, are there treatment options? And I think tyrosine kinase inhibitors is one of those that we can decrease treatment burden for sort of patients, and potentially that they might have an improved drying effect as well. So I think that this is someone for sure I would keep in mind if those treatments become available.
Have you considered port delivery system for this type of patients who require frequent injections?
Yeah, port delivery system, I think, is an interesting option to include as well, for these patients, because then you can kind of make sure that they're getting constant delivery. If patients sort of miss an appointment, you have some coverage there as well. There's some side effects to sort of think about too, or potential safety things to think about too, including sort of maybe having a higher risk of sort of endophthalmitis. There were some septum dislodgement issues, but the company has really improve those issues. But that's something you could consider as well for this patient. I know a lot of the patients who were in the clinical trials loved, and I can say this for the patients that we took care of as part of the trials at the Cleveland Clinic, but they loved having their PDS. So that's something to consider as well.
Yeah, but it is definitely a surgical option, and not all patients want to take the surgical option with its potential risks and the long-term, risk as well. So that's my case. Why don't you finish us off, take it home with some of the cases from the clinical trials?
Perfect. I would love to do so. So this is highlighting some of the patients from the DAVIO 2 study, which, as you remember, looked at patients who had received anti-VEGF injections for neovascular AMD and then received EYP 1901. So these patients were given 3 doses of aflibercept, as well as given EYP 1901, and then followed to see how they do. This is, you can see as at the bottom, those black dots are the number of anti-VEGF injections they got before sort of enrollment in the study. So this is someone who's basically getting monthly injections. And you can see that up to sort of week 32 after getting treatment, their vision remained very stable and their CST didn't change. They did not need actually any supplemental injections, really showing that sort of prolonged activity. This is another patient from the study who you can see received the aflibercept in 1901. If you follow over the first 32 weeks, you can see that there was some change in the CST and there was actually some subretinal fluid that was there. But this patient actually also did not get any supplemental injections. But the subretinal fluid actually over time, you can see at week 28 and 32 actually improved on its own. This is looking at another patient from the DAVIO 2 high dose cohort. And this is a patient who was actually able to go a year without any sort of supplemental injections. They had gotten, as you can see by those sort of black dots at the bottom, quite a number of injections, but was able to go actually a full year. And then at month 12, due to that intraretinal fluid and CST, qualified for a supplemental injection. And then here's another patient who really got nearly sort of monthly injections. And this patient was able to go 6 months without getting a supplemental injection as well. And their OCT remained very stable. So I think it's just nice to sort of, although as a clinician, it's good to see the clinical trial results, it's also just helpful to see the actual OCTs for some of these patients to see just how much fluid was tolerated for some of them and were they really dry, because that's often, it's nice to have that clinical correlation with some of these patients.
Yeah, that case really showed well how it can be quite effective and anatomic change as well. So at this point, let us do some question and answer. We have a question, actually it's more of a comment from one of the attendees saying pigment epithelial detachments are issues with the Brooks membrane pumping mechanism and so forth, and anti-VEGFs don't work very well, according to this person. So how would TKI be more beneficial?
Yeah, I think that's a good question. I mean, I think one of the nice things about the TKIs is just because of their mechanism of action, you may be able to provide suppression of at least whatever component of the angiogenic cascade is involved. You would be able to sort of control that for longer. So if that is impacting it, you might be able to get away potentially with sort of less injections. But I agree, you know, these are difficult cases to treat, and they may be people who would need some supplemental injections on top of it. We know that having sort of fluid fluctuations is not great for patients with neovascular AMD. So maybe it'll be able to help control at least some of that sort of subretinal fluid along with the PED.
So you've gone through various clinical trials. At this point, you know, without the pivotal phase 3 trial results, how would you use the current anti-VEGF versus TKI?
Yeah, I think that's a really good question. You know, the nice thing in some ways about some of the trials that have already looked at sort of TKIs is in some ways they're more similar to our patients who we often switch over to like a new therapy. Like when there's a new therapy in the retinal landscape, like I often use it on my patients who have like recalcitrant fluid or, you know, really require like frequent injections. So I can get a sort of sense of sort of how they compare to the established treatments. And it's often felt like a lot of recent clinical trials have really focused on patients who haven't had injections before. The nice thing about the way that, you know, the studies that we have so far for TKIs is they actually sort of look like the patients that I would often start new therapies on. So for me, I would try it first on my patients who I'm not able to extend out that far, or who have recalcitrant fluid, especially for patients who I know come back regularly, and are able to sort of see me regularly so I can sort of monitor how they do. How about you? Are those the sort of patients you would sort of consider?
Yeah, I mean, the what we call frequent flyers, right? Those
Yeah.
who we cannot extend out beyond 8 weeks or even 6 weeks. So those are the would be the patients I would consider initially. But I would love to see the clinical trial data and then assess. Um, Speaking of clinical trial data,
Mhm.
no signals on side effects, retinal
Mhm.
vasculitis or inflammation, because we've gotten very heightened about these incidences.
Yeah, for sure. I think one of the nice things about what we've seen so far in the earlier trials is there's not a lot of safety signal. Obviously, these are implants. We worry about implants migrating. That hasn't happened. But for sure, it'll be beneficial to see the larger numbers in the phase 3 studies to sort of see how that plays out. Sort of in a similar vein, looking at some of this clinical trial data, one of the things that is going to be interesting is that there's so many different TKIs being developed and being looked at. How are you going to be able to compare sort of efficacy between the different trials? Do you think that's going to be challenging? It's going to be easy?
I think it's going to be the former, very challenging. They're all, I mean, they call themselves TKI, but they're not the same. Not all TKIs are the same. And also the way the clinical trials are designed, it's going to be hard to compare. It's not going to be comparing apples to apples. And also treatment criteria are different, as you mentioned,
Mhm.
so depending on how the clinical trials were designed, what might
Mhm.
look better, but is that applicable in the clinical real world setting, in our day-to-day setting? I think that's going to be really interesting to continue to look at. And also, long-term data, how many more supplemental injections are given and in whom do we see more? Um, the trial designs are all different, and even the platforms are different, and the different modalities of delivery. So
Mhm.
I think, one good thing is that it's like TGIF Friday. We got lots of menus, but it's going to be hard to know which one's going to taste the best. Um, Among the different delivery system, what excites you?
Yeah, it's really, to be honest, I think we're so used to doing intravitreal injections that feels very comfortable to us. But it's really exciting to have a suprachoroidal agent potentially sort of in the mix as well. It'll be interesting to see what happens with the phase 3 study there in terms of does it mean that like the drug is going to be more available, and allow for sort of better efficacy. It's nice to have a different sort of option there. But yeah, it's interesting to have different things in the space. Um, for sure. But I agree with you. It's going to be hard to compare these trial designs. They're very different. And as you mentioned, the retreatment criteria is different for each of the studies too. So our fellows always ask us in clinic, as I'm sure sort of your trainees do, it's just like, why doesn't anyone just design a study where they compare, one to the other? And I was like, that's not the way it works. But we'll put it all together with looking to experts like you, Judy, to make sense of everything.
Well, I don't know about me, but I mean, our retina community as a whole, I think we work very well together. And even after a drug gets FDA approved, we continue to follow with the pharmacovigilance. I think that's also very
Mhm.
important. When I talk about anti-VEGFs, I say, they ask me, how does this drug work? I said, it prevents abnormal vessels from growing, and it makes the vessels stronger so they don't leak as much. How are you going to explain TKI to patients?
Yeah, I think that's a good point. I think that, a lot of the patients who I'm going to be sort of starting this on have already gotten injections. So I'm probably going to start off by sort of reframing it in a similar way and just explaining that this is a molecule that works sort of at the same sort of process, but is able to hit sort of multiple points instead of maybe just like one or two. Um, but yeah, how about you? Would you explain it any differently?
No, I think that's pretty much what I would say as well. But you know what? We are out of time. We've had so much fun. And thank you
Great.
all, the audience, for attending. Here's a QR code to claim your CME credit. And this is recorded, so please let other people know about this program. When you get the code activated, you'll receive an email with instructions how to claim your CME credit. Kat, as always, it's been a pleasure spending this hour with you. And thanks to all the audience for joining us today. Um, have a good day. Bye-bye.
Thanks, Judy.